Good morning. I am Dr. G.K. Singh. I was the founder director of AIMS Patna. Basically, I am an orthopedic surgeon who had said goodbye to mathematics after high school, but was caught by the scruff of the neck by the head of the institution and sent to do a master's degree in clinical epidemiology at the University of Pennsylvania. Since this involved an exam, the divorce with maths had to be painfully reversed, and a surgeon using hands more than a brain had to start using the brain again to become and prove to be a good user and producer of research. Since there has been a paradigm shift in the policy and practice of healthcare from what should happen, that is plausibility based, to what did happen, that is data based decision making, I found this training giving me competitive advantage in being a good producer of research protocols and papers, using evidence-based arguments in teaching, meetings, and interviews, and getting fast promotions and selections to very, very high posts. Since you too can do it by learning, practice, and perfecting the learning by teaching, treating, and producing good research, which is likely to be funded, and good publications, which are likely to help you in interviews and selection. So basically, all living beings seek pleasure, avoid pain, and learn to ignore the neutral. Thus, painful or pleasurable for individuals or communities is what we will call event of interest, EOI. And this is what best deserves to be studied. In terms of healthcare, the usual events of interest in the biological model we witness are getting diseased from normal, cured from diseased, dying from diseased, or getting disabled from diseased. The getting cured are desirable events which deserve to be accelerated, and the bad events, normal to diseased, diseased to dying or disabled, are undesirable events and therefore they have to be braked. The arrows, their direction and magnitude are transition rates, transition from normal to diseased. 100 became diseased from 1000 in 1 year. That's what a transition arrow shows. Now let us go into the transition arrows in a little bit of detail. Well, here is a cup with 10 cc's of fluid in it. It is filling at the rate of 2 cc, emptying at the rate of 1 cc. That means filling at a net rate of 1 cc. How much time will it take to become 20 cc? And the answer is 10 minutes. The formula is volume at time t will be equal to volume at time 0 plus time into filling rate minus emptying rate. Now these cc's, supposing they are prevalence values, number of people. So pt will be equal to p0 plus time into incidence rate minus attrition rate. Filling rate, incidence rate. Emptying rate, attrition rate. Amount of fluid, prevalence. So these are the transit rate calculations, and the attrition occurs because people are cured, they die, or they migrate. Now we start recording and studying the why, what will accelerate or break the transition rate and by how much. So there are multiple factors that can do it. There can be brakes, there can be accelerators. And to study these factors, the promoters or the brakes, we use what is called as a cause effect study or causality study. And here since there are multiple factors that can determine it, we use the equation which is shown here. So you see that the transition rate is equal to beta 0, that means some baseline, plus beta 1 into x1 if the factor is x1 factor, the accelerator is present or absent, plus and plus minus can go up to beta and xn. So what the beta tells you is how much would one unit increase in x1 increase the transition rate, and this value is not affected by any of the other factors right up to beta and xn. So after this you have determined which are the more powerful determinants of transition rate and which of them are modifiable. Then you can cost the risks, the logistics of implementation of each of these factors and combine them as a strategy. You can convert strategy to policy, policy to plan, get approval, execute it, monitor it, modify it, optimize it, and publicize it widely so that there is no duplication of effort. Well, let us teach you the factors determining transition rates. Here is an Excel file, and this Excel file, let us say it talks about occurrence of COVID in your community. So you have taken the percentage of UI positive during the epidemic at readings at 1 day, 2nd day, 5th day, 8th day, 9th day, that's way. That's how these are the time at which you have taken the reading. Then this is the duration after which the second reading was taken after the first. Then this is the percentage of people having COVID at that particular time. And this is the difference between the later and the after minus before. 14 upon 12, that means 2 occurred, 2 positive. And these 2 have occurred in this duration. So this is 2 upon 3. This is the transition rate. And here is the information about whether vector control was not there or present or absent. It is 0, 1 variable. There can be many. Then these are the numeric variables: lower temperature, higher temperature, humidity. So after you recognize this data set, let's see how you will proceed to analyze it. So we'll open the EpiInfo software. We launch it. We'll go to classic data. We will read this file. We saved it as a XLS file, not as a XLSX file. We'll say that it's the XLSS file, this one. And we'll browse. And when we browse, we'll try to find out where is that data set. And if we feed in F here for factors, immediately come to know that here it is. We'll open this file.
Sir, good morning, sir.
Okay. We'll say OK. We'll go to sheet 1. We'll say OK. and these are the records, and we are reading that file. We'll go to linear regression. We'll say that the outcome variable is transition rate. We'll say that the other possible explanations of this may be higher temperature, lower temperature, humidity, lower temperature, or this vector control present or absent. And we can say okay, and here you will have the coefficient, the association of higher temperature with the transition rate with its p-value, along with the standard error, and each of them you have, and this much you have not been able to explain. Here is the R square of this equation, the correlation coefficient. The residual square that we told you is so important. The plus residual and the minus residual from the trend line is squared to take off the signs and then summed. So this is the correlation coefficient. So this is how you can determine which of these factors is significant in finding out whether the transition rate is accelerating the transition rate. Now this high temperature is negative, that means it's breaking it, and humidity is accelerating it. So this is how you can determine factors determining transition rates. So what does the research try to answer about the event of interest? It tries to answer what precisely, without false positive and false negative rate, occurred when, where, in whom, that is descriptive statistics, descriptive studies, how and why, those are the causality studies. Then what is the research that goes into program development to respond to the event in a manner that the pleasurable are stimulated and the painful are braked. Now we have to ensure that we do not mistake in saying whether the event of interest is present or absent in a particular case. That means we should have very low false positive and false negative rates. So the diagnostic strategy is to minimize the false positive and false negative rate. For every diagnosis, there is a gold standard in which we assume that the false positive and false negative rate will be 0. But in case the gold standard is costly, invasive, dangerous, not accessible, then we must use a surrogate, which can be used singly or in a series of parallel combinations. You can use many surrogates and combine them to get values close to the gold standard. And therefore, these studies basically validate, calibrate, or choose an optimum cutoff for the surrogate as compared to the gold standard before the surrogate can be used. So now validation is where surrogate and gold standard both give positive negative result. There you use the 2x2 table and you are able to report sensitivity, specificity, positive negative predictive value, positive negative likelihood ratios. Then you can have a XY scatter plot when both are yielding numeric results. For example, a ultrasound densitometry or a DEXA densitometry both are getting you mineral mole density, which is numeric. So here you have to have a x and y axis. You have to develop a scatter plot. You have to draw a line which is called as the trend line or the least square line, which is closest to those dots. And you can use to predict the value of the gold standard given a certain value of the surrogate. Using this or using the equation that went in to develop the trend line. Then if the surrogate is giving blood sugar and you have to find out whether this fellow is uncontrolled diabetic or not by HB1AC. So here gold standard is categorical, yes, no, and the surrogate is a number. So you have to choose the best cutoff number that will maximize the true positive and true negative diagnosis of the gold standard. So this you can do by maximized likelihood ratio tests, or you can do by receiver operator characteristic curves. Now, finally, you are welcome to learn to do such studies and tell sensitivity, specificity, positive, negative predictive value, positive, negative likelihood ratios of surrogates against gold standard. And you can also draw an XY scatter plot, determine the least square line, and you can also tell us the best cutoff to differentiate between HB1AC positive diabetics and non-diabetics by looking at fasting blood sugar levels. But what is most important follows in the next slide. Finally, there is no investigation more powerful in diagnosing the event of interest than multiple indications provided by a comprehensive, precise, and valid clinical examination and history taking, and its interpretation by an experienced clinician. This is far more usable, safe, logistic diagnostic strategy than the costly, invasive, dangerous, painful, or not easily available strategies like MRI, PET scan, CT scan, which have been grossly overused in the world. Let me give you an example. If we randomly pick up any citizen, Indian citizen, say that you are tubercular, then the chance that we are right are 2% because the prevalence of tuberculosis in the population is 2%. But if we pick someone from the hospital, the chances would increase. If we go on adding information, like picked up from chest OPD, has cough for 3 months, has blood in the cough, has evening rise of temperature, responded to ATT, then combined all these indicators greatly enhance the probability of our being right if we say that that person with all those characteristics is tubercular. So clinical examination and clinical prediction rules, which have been validated against gold standard, are very powerful methods of saying whether the event of interest is present or absent, especially in field conditions. This diagnostic test calculator I developed just for you, dear participants. It can give you results needed to publish papers when you are trying to validate or calibrate surrogate methods of diagnosis against gold standards. So if the surrogate gives numbers output and the gold standard yes, no, then you have to learn to choose a correct cutoff. Then if the surrogate and gold standard both give yes and no, you have to report sensitivity, specificity, positive, negative predictive values, and their 95% confidence intervals. And when the surrogate and gold standard both give results in numbers, you have to develop a trend line and use it to predict the value of the gold standard given a certain value of the surrogate. And the accuracy is achieved by minimizing the residual square. Residual square is the number by which the trend line is close to all of the dots in the scatter plot. So you just do Ctrl click to open the link, and I have shared the link with Archana. She'll share it with all the participants. Well, this calculator we'll try to use. So you press Ctrl and you hit at this link, and the calculator is herewith loaded. Now, in the first instance, your surrogate is yielding results in numbers. So you arrange the cutoff at 1, 2, 3, 4, 5, 6, 7, 8, 9. It can be fasting blood sugar 60, 70, 80, 90, 100, 110, 120, 130, 140. And by the gold standard, you would want to say whether the person has diabetes or no diabetes. So you actually feed in the correct numbers in each of the cells, and as soon as you get that, you get these sensitivity and specificity estimates. You sum up these sensitivity and specificity estimates, and as these numbers, you would find out that 1.48 is the highest. So this is the cutoff which will give you the maximum of the sum of sensitivity and specificity. But you may choose lesser sensitivity or more specificity depending on what is the negative cost of false positive or false negative. So you can vary this value also, but this is a calculator which will give you the best cutoff of the surrogate values against the gold standard if the gold standard is giving plus minus results. So this is one. Then if the surrogate and gold standard both are yielding yes and no data, then you fill in the surrogate disease positive negative and disease positive negative by gold standard. Fill in these yellow numbers. You can do it in that calculator, and you will get point estimates of sensitivity, specificity, positive negative predictive value, positive negative likelihood ratios. You would also get the 95% confidence intervals of sensitivity, specificity, positive, negative, positive predictive value and negative predictive value. So if there are 95% chances that if you repeat the study 100 times, the values of sensitivity and specificity will fall between these intervals. So you have point estimates and you have interval estimates of sensitivity and specificity if you fill the numbers in this column correctly. You can change and fill and you can get these results. The third thing is that if the surrogate is giving you numeric data and the gold standard is also giving you numbers, so you try to draw a scatter plot. So these dots are the scatters. For example, the value of 6 in this case will correspond to 4 in the gold standard. So each dot represents the value in the same patient by the surrogate and the gold standard. Then you draw this line which is called as the least square line. This is supposed to be the closest to all the dots. So this dot is higher, so there's a positive residual, and this dot is lower, so there's a negative residual. To take off these signs, you just square the residuals and you sum the r square, and lesser the r square value, closer the line is to the observation. So closer is the prediction to the observation. You can use these trend lines. So example, if the value of surrogate value is 4, then it's about 4.2 gold standard. You see, or you can use this equation. Gold standard value will be equal to 0.6189 into x plus 2.3939. You can use this equation, or you can use this normogram if both surrogate and gold standard yield numeric values. After acquiring standardized capability to accurately detect presence or absence of the EOI, the strategy is applied over sufficient sample size in a survey or surveillance mode to define the prevalence of the EOI in the target population. And this data usually contains the time, place, and percent distribution data. That is the when, where, and in whom the event of interest is occurring. And such studies are called as descriptive studies. And of course, we have told you that two prevalence rates at PT and P0 are known. Then we can determine the PT, P0 and T are known. Then we can determine the incidence minus attrition rate by the formula PT is equal to P0 plus T into incidence rate into minus the attrition rate. In many diseases, the attrition rates are nearly zero or assumed zero, like diabetes. And there, the IR minus AR is replaced by IR alone. Next, the event of interest accelerating or braking factors and the magnitude of the braking accelerating effects are determined in medicine. How fast is there a transition from normal to disease, or from disease to cure, or from disease to dead, or from disease to disabled? And which of the etiological factor is accelerating or stopping this change? So these studies are called as cause, treatment, type, effect studies. Now you'd see that when you are trying to relate etiological factor to effect of disease or prognostic factor to effect of outcome, then you are only observing the etiological and prognostic factor. But if you are giving a treatment, then you are not only observing but actually administering the causative factor, and therefore your ethical and moral responsibility is greatly enhanced. Now let us study this 2 by 2 table, which is the heart of all epidemiological studies, and this is the cause effect table. So you can say that does drunk driving cause accidents? So you take people who were drunk drivers and who were not drunk drivers, a cohort of them, follow them forward, let us say for 1 month, and find out how many had accidents. So here we may say that 10 out of 100 had accidents amongst those that drive in a drunk manner, and only 5 out of 100 had accidents in those who did not drive like in a drunk manner. So these numbers would say 10 upon 100 is the risk of an accident, given that you drink while driving, you do drunk driving, and 5 upon 100 is the risk when you do not do it. But so this is risk. Let us say the 10 out of 100 is the risk having an accident if you drive while you are drunk. But the odds are 10 upon 90. 10 upon 90. The difference between the risk and the odds is that the 90 of the denominator of the odds does not contain the numerator. Similarly, risk and cause negative is 5 upon 100 and odds is 5 upon 95. Then the risk ratio is 10 upon 100 divided by 5 upon 100, which becomes 2. And this is called as risk ratio or relative risk. Then the odds ratio is 10 upon 90 divided by 5 upon 95, which comes out to be about 2.2. The risk difference is that 10, 10 minus 5, that means 5 more cases had accident in 100 because of drinking. So this is the risk which is attributable to drinking. It is called as attributable risk and it is also called as risk difference. Now, before we leave this slide, then we study how these numbers are populated. How do these numbers come? By what study design? So you take a cohort of cause positive, cause negative. That means you take a cause of people who are making license and find out whether they drink or not. Follow them for 1 year and find out how many had accidents. So the effect comes late. The direction is forward in time. So this is called as a prospective or a cohort study. But if the outcomes are rare and remote, for example, if the accident would have occurred in 80 years or lifetime, then you can't follow them for that period. So in rare remote outcomes, you start with the effect. You say he has had an accident, he has had no accident, and you find out whether they drink or they don't drink. So that is in retrospect. Okay. And that's why these are called as case control studies, because you begin with case and control, and you also call them retrospective studies. The problem with retrospective studies, with case control studies, is that you have to artificially fix one case for one control means 50% prevalence of cases, which is not true in the general population. So in case control studies, you have to use odds ratio, not risk ratios. And you have to do these case control studies with only rare and remote outcomes. And you have to report odds ratios. That's what you have to remember about case control studies. Well, cause is administered by the researcher in experimental studies, unlike observational studies where it is only observed. Now, this brings a great ethical responsibility. Informed, informed consent is a must, and it should be without lure or duress. You have to be very sure that you'll do no harm. You have to ensure equity. You can't test a costly treatment on poor patients and then use it for rich ones. You have to really good justification for testing the new treatment against old. That means the old treatment should have the problems and there should be a possibility that the new treatment would do better. You have to have built-in plan to detect and manage unexpected adverse events. And given that you detect them, you must have a plan to help the victim and and institute top rules till the matter is resolved, then you may plan to do interim analysis so that you can detect the better treatment earlier and then give the better treatment to all of the study participants. Also, there is a human risk involved in creation of this new knowledge. Therefore, you must ensure its use by widely publicizing it and try to ensure translation into policy practice. And this publicity would also help avoid duplication. The second component after ethics is that the treatment groups must be equal on all other factors, which can be the other explanations of difference in result. For example, if I say that the conservative treatment of intercondylar fractures did better than the conservative treatment, my detractors may say that they did better because more grade 1 and 2 fractures were in the conservative group as compared to the operative group. Thus, here, besides the conservative and operative treatment, there is another factor which is explaining the better performance of patients treated conservatively. Now, these other explanations are called as confounders, and only random allocation can take care of known and unknown confounders. So random allocation over a sufficient sample size must be tested before you believe a randomized controlled trial. Now, therefore, sample size are difficult because treatments are costly, not affordable, and random allocation is disturbed by patient preference. Therefore, if short RCTs are available and it is not possible to do a large RCT at a big center, then you can combine result of simple randomized controlled trials to get more precise estimates of effects, and this is called as meta-analysis.
Let me show you this EpiInfo software which you can download from the net. It has been developed by CDC Atlanta. It has many functions, but let me show you the StatCalc function. So this is the StatCalc, and you can sort of open the 2 by 2 table. Here, let us say that 10 amongst those who drink had a lifetime car accident, and only 5 who did not drink out of 100 had a lifetime accident. That means 95 did not. So 5 out of 100 had accident in the non-drinking group, and 10 out of 100 had an accident in the drinking group. So as soon as you do this, you fill these numbers: exposed having the outcome, exposed not having the outcome, exposed not exposed having the outcome, and not exposed not having the outcome. You press done here, and you get these point estimates, which means estimates of odds ratio, relative risk, and risk difference. The odds ratio, these are point estimates, single numbers. But then you have this lower and upper limit of 95% confidence intervals. For example, in odds ratio, it ranged from 0.69 to 6.416. This means that if we do repeat the study 100 times, 95 times the odds ratio would be between 0.69 to 6.4. Now, if the risk or the odds were equal in the exposed and the unexposed, then the value of the point estimate should have been 1, and that is called as the null value. If the confidence limits, 95% confidence limits, includes the 1 value, that means 1 is between 0.69 and 6.41, then it means that the association is not significant at 95% confidence interval. Here also, since the p-value that you can see here, 0.17, 0.18, 0.28, none of them is below 0.05. This says the same thing, that the association between having an occasional drink and having an accident throughout your life are not significantly associated. So this is what we clear. And then
here we take an example of if elbow fractures are treated conservatively and if they are treated operatively, what is the chance that which treatment should I choose? So 80 out of 100 did better in the conservative group and 40 out of 100 in the operative group. Obviously, there was a 2 times greater risk chance of having good results with conservative treatment as compared to operative treatments. But then the argument was that there were more undisplaced fractures in the conservative group. And that could have explained the good results in the conservative group. So we had to then draw these 2 by 2 tables with the displaced fractures separate and undisplaced fractures separate. So in these 2 tables, the displacement of the fracture has become constant. Now this example of another factor explaining the result, that factor is called as confounder. Here it is displacement of fracture. So the relative risk in undisplaced is unaffected by the displaced stature, and the relative risk in the displaced 4.8 is unaffected by the displaced undisplaced status of the fracture. Therefore, if we combine the relative risks obtained from the undisplaced and the displaced table, that is called as Mantel-Hansel's adjusted relative risk and adjusted for displacement of fracture, adjusted for the confounder status. So here you see the EpiInfo calculator being used for the crude odds ratio with 80, 20, 40, 60 numbers. Then we did it for undisplaced fractures, that is 30, 10, 30 is 40 numbers. Then with the displaced fractures, 50, 10, 10, 20 numbers. And then we were able to combine these 2 tables, displaced and undisplaced, to get a summary statistics. And that gives us an adjusted odds ratio and an adjusted relative risk, adjusted for the confounder status, which means keeping the effect of the displaced and undisplaced fractures constant. The conservative and operative treatment were related to good and bad results by 2.034. relative risk, and that was the 95% confidence interval. Well, first let me show you this Excel file which all of you can make. You see, this is the ID or case number. This is the, you'll enlarge it a little bit. It's too much enlarged. So this much. So this is the case number. Here is the status of the exposure. No exposed in the first 10 and exposed 1 in the next 10. Here is the effect 0, 1, present or absent. So this is a categorical effect or a binomial effect, present or absent. And the problem here was this. This can't be 4, so this has to be 1. Okay. Now here is confounder 1, which is yes, no, and the other is confounder 2, which is numeric. So this is your data set. I mean, this type of data you'll have to fill, you'll have to convert your data sheets into this type of data, and then let us start seeing what to do with it. So here we minimize it, we open the EpiInfo program, we go to the classic, we go to read, we say it is a XLS file. Remember that many EpiInfo programs may not read the XLSX file. Then we go into browse, and with the browse we want the location, so we go to the desktop where we have stored it, and we say test data 1 and we open it. And as we open it, we get this sheet 1. That's what we'll read, because XLS files may have many sheets, and there are 20 records. We know that there are 20. Still we can list them and see, list all of them and see whether they have been correctly reposited or not. After this, we want to test the cause-effect relationship. When the cause is categorical and the effect is categorical. Cause is treatment A, treatment B, and effect is response, no response. So we draw this 2 by 2 table. The exposure is treatment A, treatment B, and here the exposure is exposure, and the outcome is good and bad result, and that is the effect. And we make this 2 by 2 table. So with 0 treatment, 8 out of 10 responded. With 1 treatment, 6 out of 10 responded. And here we go down and we get an odds ratio, a point estimate. So there was 2.66 times greater chance of good result with treatment group 0 as compared to treatment group 1. And if we repeat the study 100 times, 95 times, the value will range between 0.36 to 19.712. Now, since this interval includes 1, which is the null value, supposing there was no effect, the value would have been 1. That's why this odds ratio, this association is not significant at 95% confidence interval. Here is the risk ratio and its 95% confidence interval, and here is the risk difference and its 95% confidence interval. So after this, we show you when the effect is numeric. For example, how much was the reduction of blood pressure with treatment A or treatment B? So this N effect is numeric effect, and we would do a linear regression, not logistic regression, when the effect is numeric, and we'll try to explain it by the exposure, that is treatment type, and if we want to make the confounders constant, we can put confounder 1 and confounder 2. So this exposure would be related to the effect, exactly keeping the confounder 1 and confounder 2 constant. So here it is. You see the coefficient of exposure is 29, confounder 1 is 2.253, which is very small as compared to that, and this is minus 0.3 confounder 2, and the constant unexplained is quite high, p value is very high. So this is the way to relate exposure to the numeric effect. That means how much was the reduction of blood pressure, keeping confounders constant. This confounder can be 1 to 10. All will be kept constant while the regression model is finding out the coefficient or relationship between exposure, type of treatment, and the outcome, that means reduction of blood pressure. But now supposing the outcome is yes, no, responded, did not respond, normalized, not normalized, then we put the outcome variable as not N effect but effect, and the other variable as the exposure. Then we can put confounder 2, and what we get is a logistic regression model which tells you the odds ratio and the 95% confidence interval of the odds ratio and the p-value of when exposure yes no is linked to the effect. And then there is this confounder 2 has been kept constant while this odds ratio is adjusted for confounder 2. So this is the method of using unconditional logistic regression to find out a relationship between determinants, that means the exposure and all the other explanations of the effect being kept constant, that means confounders being kept constant, and therefore this is the relationship between the exposure and the outcome, which is a yes-no outcome. Now if it is a time-related outcome, it is either a Kaplan-Meier survival when it is 1-to-1 relation, or Cox proportionate hazard model when there is more than multiple explanations, just like linear regression or logistic regression. So this is the regression analysis which is used to find out the relationship between cause and effect, keeping other explanations of the effect constant. Research is a costly proposition, not only in terms of money but also in terms of human risks. Thus, its valid, precise results must be used to benefit the population who took the risk and should be used as widely as possible. Research papers should not decorate shelves of libraries. By translational research, existing good evidence is identified, appraised, analyzed, and disseminated to decision makers and used by them for creating policies, plans, programs, resources allocated. The program is documented and got approved. Then it is implemented. Interim monitoring is done to find out problems, and the problems are solved, and finally you have an optimized, successful program based on evidence. Now this standardized response to the event of interest, to avoid pain and to seek pleasure, is disseminated for wider use and preventing duplication. Let me share with you an example of simple research which achieved a lot, and thus you can sort of say that study designs exist, but mind must be kept open for newer ones. So here 5,000 AES, acute encephalitis syndrome, and Japanese encephalitis in North India were occurring since 1994. 1,000 out of 5,000 would die, about 20% mortality, and 3,000 would be disabled for life. Response till the birth of AIIMS Patna in 2011 was non-specific, more treatment oriented, and thus ineffective in preventing the condition. So the AIIMS Patna, Rajendra Prasad Center for Research, Patna, and Bihar State Task Force collected data on latitude and longitude through a mobile, along with the demographic data and the data about the patient on the day that the symptoms started. So we had an information on the Excel sheet which described the latitude and longitude, the place, the time of onset of the epidemic, and the demography of the person who suffered. We use the EpiInfo program developed by CDC Atlanta to generate this micromap. Now this was actually a video is generated, and you can see over time that this is the time distribution. Now as this curve goes more and more, you can see these dots appearing, and you can find out when which dot appeared. So this is a video, but this is the final snapshot that you see. I would like you to concentrate on this picture for a few seconds and tell me whether it suggests something to you. Write it down on a paper and try to test yourself whether you could detect the truth or not. So observe the red dots. They are limited by a line. They can't go towards the left lower corner, and this line is the Saryu River. Conclusion: waterborne fecal-oral spread of the enterovirus, which is perhaps growing in the intestine of the carriers, spreading from fecal contamination of the North Stream upstream to the mouth of the people living downstream, and is unable to cross the fast flowing stream of midstream of the Saryu River. So one thing that we suggested was that we put diverters on the pillars of bridges so that the midstream is diverted to the north bank and it is able to wash off the infecting fecal pollution. The second thing that we could have done would be to ensure no use of surface water for toilet or drinking. Third, we could have done safe drinking water campaign. Nitish ji agreed to the safe drinking water campaign, and we did it in Muzaffarpur, distributing chlorine tablets and educating people not to use surface water for toilet or bathing. So these are the results of the clean water campaign done in Muzaffarpur in 2014. 2014, 1347 cases reduced to 64 in 2015. More than 1,000 saved in Muzaffarpur alone and estimated 4,000 overall from 2015 till perpetuity. The presentation was done in UP, implemented here, and now the epidemic is history. So don't be satisfied with the next patient, please. Don't look for costly, difficult solutions to huge health problems. Remember, condoms eradicated AIDS and vaccines, polio and smallpox. Clean water also eradicated the annual cholera epidemic around the Thames River in UK. Prevention of cadmium pollution of the Ouch Ouch River in Japan decreased the chances of distal renal tubular rickets, the Ouch Ouch disease. There are numerous success stories and out-of-box study designs which have done good. So know the study designs, but don't stop thinking, improving and making new ones. Thank you for the patient listening.